What I have to do now is to so just go to the teams. Teams, yeah. Then share, is that correct?
Yeah, that's right. Yeah.
Okay. Slideshow.
Let me just.
There's an option of like present in Teams over there as well. But
it's because people are joining on Teams, so
just connect this.
yeah. But that'll give me some freedom to move around. Is there anything you can take out and you don't need? Yeah, that's the most.
Yeah.
Oh God. Okay.
Looks like this one doesn't work.
Should it be?
The one. I've got two of them. To give it a try. Yeah, this one works. There you go.
It's 2:00, you know. How many people have joined there?
We have like just two online for now, but it's just 2:00 now, so I think it'll
So
take
we
some
wait
time.
till 2:05.
Yeah.
We wait till 2:05.
Once it's done, you
So
can just
this-
disconnect everything.
This mic also takes me up here, is that correct?
No, this doesn't work for,
Okay.
I think it's the laptop mic,
laptop.
which is,
Okay, so I'll just stay close
yeah,
there.
yeah. Or if you want to turn the video on for questions. you can-
No, that's fine. I'll ask them. They can always ask me through here.
Sure. Okay.
You may turn the video like how?
Yeah, just,
So I can see the people there. You can switch off the camera.
that's fine. Do you, let me see.
You want to put me there, is that correct?
Yeah, I'll just,
Whatever way you think is best.
or you could sit down here for some time for questions, if that works better. Yeah, it's not showing anything. For some reason.
There's another one here. What is this one here? That's me here again.
Yeah.
Okay. So that's normal, isn't it?
Yeah, but it should be showing like,
Should be
so
showing.
it's not showing any image. Maybe because it's connected to your laptop. I don't know why it's not showing because this is turned on. Can't see the reason why it's. Yeah, now I think they can see you.
Yes, they can. So you want us to be this way or? Okay, well, that's fine. That's what they want. Okay, so let's go back to our presentation mode.
It is sharing at the moment.
That's it. This is more for the computer, isn't it? Okay, I think we can start now. Hello, can everybody hear me very well? Can
Yes,
you all
we can
hear
hear you.
Oh, okay, you can, yes, okay. Thank you very much for logging in, those logging in face-to-face and physically and online and all that. I'm Dr. Walter Mmeka, consultant medical oncologist here in ULTH. It's a pleasure and a privilege to be talking about oncology, cancer chemotherapy. We just have, it's more an overview because I reckon you guys are internal medicine, trainees and all that, and registrars. We also have some oncology registrars as well joining us. So hopefully it's going to be a learning experience. I hope you can hear me very well. Can you hear me very well? Hello?
Yep, can hear you perfectly.
Perfectly. Okay, very important. Okay, so the lecture format is going to be 60 minutes of knowledge teaching and then a 15-minute break, and then we'll go into 45 minutes of clinical integration with some case-based discussions and all that. So just to keep us alert. But even while the lecture, we may be seeing some slides to answer questions or deliberate on a few. So overview and introduction to cancer chemotherapy and also cancer itself, a little bit of knowledge about it. That's what this whole thing is all about, because some of you are IMT trainees, graduates, registrars and all that, where you might be in A&E and then you're seeing an oncology patient who's just had chemotherapy and also other cancer-related complications that arise from this. So it's more of an overview so you can understand the drugs we use, what we do, and also to take some basic actions about it, recognizing side effects and all that. So we're going to look at introducing you to some terms that we use, a little bit about cell cycle. For some of you doing some of your USMLE exams and MRCP UK, I think you'll find the cell cycle quite useful because these are part of your basic science domain there as well. We'll talk about commonly used cytotoxics, look at some routes of administration, deployment, pre-chemotherapy assessment, response, resistance to chemotherapy, complications and management. We'll have a quiz session and all that. And we'll also look at some of the policies around starting chemotherapy, 2-week wait and all that. So what is SACT? SACT is systemic anti-chemotherapy agent, anti-cytotoxic therapy. So no longer just about saying it's chemotherapy, you needed to say SACT. That's what we're saying these days. So it's not everything previously was chemo, but now that definition has broadened up a lot, So there's a vast number of drugs now used in treating cancer. So, medicines containing chemicals that are directly toxic to cells, preventing their replication or growth, so making them active against cancers is a cytotoxic agent. And in that SACT category or umbrella, we have immunotherapy now in the landscape, and we also have targeted therapies that target the genes that drive these cancers. So the umbrella is increasing all the time. And even in targeted therapy, we have hormone therapy, as you can see in breast cancer patients and all that, and prostate cancer patients, that we use hormonal manipulation to treat this group of patients. So systemic anti-cancer therapy, chemotherapy, immunotherapy, targeted agents, and of course, radiotherapy is also a target, because sometimes we have some radionuclide materials that we inject into the body to treat cancer, like in prostate cancer, we have alpha radium-223. We also had lutetium-177. I mean, these are radioactive materials we use in treating. You could have if you wanted a full list, you can go into Cancer Research UK. You see loads of treatment and targeted therapy drugs. So as I said, despite us using or in spite of us using chemotherapy, these patients, one way or the other, may end up in A&E or in the ward or in clinic, or there might be, treatment-related complications from endocrinopathies, diarrhea, neuropathy, pneumonitis, and all that. So there's always going to be concern. So it's important for not only cancer-specific departments or team or specialist group, but also the wider medical audience of general medicine and general physicians and general surgeons as well in acute care, A&E, acute medicine, or wherever you find yourself. Or they may even land up in your wards as well. So it's good to have a bit of an idea of what's happening. And if you don't know what to do, please contact the oncology team, because we have an acute oncology service, which I will talk about a little bit. So the aim of cancer chemotherapy is to cure where possible and palliate where cure is not possible. And let me emphasize what palliative chemotherapy is. Palliative chemotherapy is about improving survival benefits. Watch that word, survival benefits, to give patients survival. In fact, the term we use these days is for patients to live with their cancer as long as possible. So it is to prolong life, despite it being called palliative chemotherapy. It's called palliative chemotherapy because we're never going to cure them. All right? So palliative chemotherapy is not a symptom control. That might be your thinking before. No, that's a secondary gain of using chemotherapy, okay? 60–70% of the job of an oncologist is actually palliative chemotherapy, but we do give them survival benefits up to 10–15 years for breast cancer, prostate as well, 10–15 years. Sometimes with palliative chemotherapy, testicular cancer patients, literally 98% of them could live the rest of their life, if not be cured of it. So, but it was palliative chemotherapy. So the main goal of palliative chemotherapy is overall survival benefits. And the secondary gains are things like symptom control and all that. Because if you've not come to such teachings, you'll be in error that, oh, it's all symptom control, blah, blah, blah. No. It's to prolong life. Very important for you to understand that, okay? So effective use of it is so important to understand the principles of use, the tumor biology, the cell kinetics, and pharmacology and resistance. So it's very important. But I understand I'm speaking to more IMT group because sometimes I use these slides for postgraduate students. So I'm not going to dwell too much on these things, but for some of you writing exams, you'll be asked some of these basic sciences. So that's why it's good for you to be aware of them, okay? So just on the changing cancer story, by 1970, it was about probably average survival for most cancers was about 1 year. But that trend has improved almost 20 years after, where it has improved to 2 years in 1990. And even going to 2020, we're talking 10 years for some cancer now. I said the term has changed. It's about living with cancer. And the number of patients are also increasing, as you can see there, that are living with cancer. So we're keeping them alive because of the targeted treatments, immunotherapy, surgical techniques, screening, and all that. So all these have improved survival over the last 30 years or thereabouts. So it's about living with cancer. That's what we normally say. We want the patients to live with it like any chronic disease, COPD, or whatever. In fact, most medical conditions, if you ask, they're not really cured. Alzheimer's, multiple sclerosis, Parkinson's, diabetes, you just name them. I don't want to name them. We could go on and on. Your kidney problems, they end up with dialysis. Even if you had a heart attack, you were stented. It was just, in fact, you could have another heart attack in a year, even with a stent, okay? So the whole thing is about making patients live with it. I was with a professor someday, he said even a lower respiratory tract infection, he noticed he never cured anybody. They kept coming back with exacerbation of COPD every few months. They kept coming back. And if you look at post-mortem analysis, the commonest cause of death is bronchopneumonia. on post-stem studies. So you didn't really cure anybody. So it's to take away the stigma around cancer. It's one of those diseases. In fact, 5-year survival for some cancers is almost better than COPD or Parkinson's or heart failure. Okay, so the cancer patient will even live longer with good quality of life than those patients. So we must understand what it means to live with cancer. It's like living with any medical problems. There are 3 cancer groups here. It's very important to learn that prostate cancer, cervical, breast, endometrial cancers, kidney cancers, even colorectal cancer, early stage, lymphomas. 5-year survival for these cancers are so great that patients can live very long. Even breast cancer, we have patients coming 15 years, even with metastatic disease. They are still on the go with multiple lines of treatment. Okay, colon cancer, some of them can live up to 5 to 10 years. All right, so many there. Hodgkin's lymphoma, excellent. They could be treated. Some of them can even go into curative treatment and then relapse after 10 to 15 years. So a lot of trend there for the group 1 patients. The group 2 patients, a bit borderline, but they could also live that long as well. Then a very poor prognostic group of cancers is more hepatobiliary, where you have pancreas, liver cancers, lung, and extreme metastatic colorectal cancer, esophageal, and stomach, and brain tumors. GBM, median survival is about 13 months, really. So these are very poor prognostic group of cancers for you to be aware, all right? But certainly breast and prostate will be top on the list with lymphomas, okay? So it's good to have this understanding when you come close to our patient, because you cannot say somebody's having palliative chemotherapy and then you say it's not for resuscitation. You must consult the oncology team and the oncology consultant, because the consultant has to say, okay, okay, yes, and agree with the team, the medical team, that patients are not for resuscitation. So having palliative chemotherapy is not a reason for somebody not to be resuscitated. It's a consultant's call, all right? Otherwise, you could misunderstand the trend, because somebody still has a long time, many years to live, isn't it? Despite their cancer. But there are some of them is very bad. We say, okay, it's not for resuscitation. We'll treat them for a year or 2, and it's not looking good anymore. All right. So you must understand these things. So the 2-week wait is another concept that you need to be aware of. Okay. As soon as a cancer patient, is suspected, is referred straight and must be seen by a specialist within 2 weeks of their GP referral. It's good for you to be aware of the 2-week wait, because some of you might end up as GPs as well. So you must understand that as soon as it comes to you, make sure it gets to a specialist within 2 weeks. Okay. At the moment, the NHS targets about 93% of patients to be seen within the 2-week time frame. So we're doing a lot there. We're not there yet. All right. Because trends can change in the circumstances of cancer. So that's just the part. Within 2 weeks, must see a consultant. That's not happening at the moment. We're slightly below target. And within another 31 days, 32 days, a month, the cancer must be confirmed or ruled out through investigations, okay? And then within 6 weeks, whether MDT or whatever, those should have been completed, and the patient should have started treatment within 62 days. That's why you may hear us talking about the 62-day breach if the patient has not started treatment, okay? So 31 days, patient should have been confirmed and investigated completely. And by 62 days, patients should be starting treatment. All right, what are the goals of cancer chemotherapy? The goal is to cure where possible. Some cancers are actually curable. Testicular cancer, for example, okay, they are curable, and some lymphomas as well. And sometimes we control the cancer. How do we control the cancer? If you come to our MDTs, we're talking about liver resection. Somebody has colon cancer and there's a spread to the liver, but it is resectable. So if you resected, okay, let me just stay at that liver resection. If somebody had colon cancer with mets to the liver, the 5-year survival, even if you treated them with chemotherapy alone, is about 10%. But if you're able to resect the liver, you could bring up the survival by 50%. So a five-fold rise. So that's why so these are one of the ways to control cancer. All right. HIPEC is hypothermic intraperitoneal chemotherapy that is injected into the peritoneum for those that have peritoneal mets, because peritoneal mets median survival is about 12 months. So we send them to Basingstoke or Christie in Manchester for chemotherapy to be poured intraoperatively after the peritoneum has been ripped off. This improves the survival again by as much as 40 to 50%. Otherwise, they'll be dead in 1 year. So these are all strategies to improve cancer. Mastectomy, for breast cancer, after you had a mastectomy, the survival just changes for the breast cancer. But without mastectomy, patients will be dead within a year. Within a year, most patients will be dead. But if you took it out, survival could go up to 10 to 15 years. So these are all forms of cancer control through surgery as well as with radiation. Palliation, we've explained what palliative chemotherapy means. The primary goal is overall survival. The other terms, which some of you, if you come into training with us, median progression-free survival, objective tumor response rate, hazard ratio, and duration of response. These are terms and parameters we use in assessing treatment when patients have started treatment with us in cancer care and also in the context of clinical trial. But palliative chemotherapy, the primary goal is overall survival, is not symptom control. Symptom control is a secondary benefit. Okay, great. Of course, there are a lot of side effects with treatment. We have visual disturbances, skin changes, dryness, bladder, bowel, diarrhea, nausea, and hormonal effects as well, especially females between 40, 50 having chemotherapy could push them to early menopause, fatigue, and all that. And of course, there are psychological consequences of having chemotherapy for patients and families. Now, you must understand that it is not in isolation, okay? These patients with cancer have hypertension, there could be obesity, mental health issues, chronic heart disease or kidney and all that. So, the goal of treatment remains to treat with some margins of safety for the oncologist. It is not a contraindication, but it's to treat these patients with a bit of caution, because even by the time they are 65, 70, they may have a lot of comorbidities, but it does not preclude them from treatment. So it's good to be aware. And that's why the medical populations like yourself, you must be aware of this intermix of cancer, chemotherapy, and their medical problems. Okay, so as I said, we have an acute oncology service in the unit here in the hospital and across the trust-wide in the United Kingdom. There's an acute oncology service which is very specialized to deal with such patients. But after hours, they usually go to A&E, okay? So from the primary community care, they go to A&E for the emergency service. And the A&E also has access to us as well, the acute oncology service. And then there's a 24-hour, advice and guidance line from oncology as well. And of course, sometimes this patient could end up in acute medical units for urgent care. But finally, those after hours, somehow acute oncology remains. So it's just to bring it to your awareness that we have an acute oncology support service, all right, which runs in the hospital and across most NHS trusts as well to support these complications. But you also may be on the primary or the community care or the emergency desk. You need to be aware to know what to do. Okay, so that's about the cancer pathway and the politics of getting them to treatment and the framework that runs behind it to mitigate these complications. So if you want to talk about cancer chemotherapy, you must understand the cell cycle. This is a $1 million spin which when I say $1 million, multi-billion spin wheel, because a lot of research and science goes on this little wheel to manufacture drugs. So the cell cycle simply, the G1 to the S phase is about 13 hours. There's a lot of synthesis going on. Okay, at the time the cell is not dividing, it's called the G0 phase, a very short time. But oftentimes the cells jump into the synthetic phase, which is about 13 hours or 14 hours every day replicating. And they have the G2 or gap phase, and then the mitotic phase, where after they've replicated, no, after they've synthesized, they now replicate and divide. So it's called the mitotic phase there. All right. So the enzyme that catalyzes this, that catalyzes the system is called cyclin-dependent kinase. Even right now, we have a target for that enzyme. It's used in breast cancer patients to treat their cancer, and the results are quite impressive because once that enzyme is arrested, cells cannot go through that cycle anymore. They get arrested and they die. Cancer cells. Cyclin-dependent kinase inhibitors, ribosiclib, palbociclib. All right. I'm not going to trouble you with so much of some of these numbers to bring to your awareness the way some of these drugs work. Okay. So again, these are another way to look at it. It's still what I've been talking about in case you didn't get it. The mitotic phase is where they actually divide, okay? And then the S phase is where you have your DNA synthesis and DNA replication, all right? So cancer comes through many paths and pathways. There'll be oncogenes. Maybe some of you have heard of oncogenes. Oncogenes leads to an amplification of the tumor cells. So the tumor cells stack up. That's what oncogenic tumor pathways are, okay? So we've got some genes that drive it, RAS, MYC genes, and all that, okay? And then we have the tumor suppressor gene on the right, whereby there's a deletion or loss of function of one of the allele pairs of the gene. So these altered gene expression pathways, which could be from chemicals, radiation, viruses, or familial association. Those are the triggers. That's one of the ways cancer, could be triggered, apart from chronic disease and other factors. And once it's triggered, it goes into development of the primary tumor. Decreased apoptosis means the cell cannot die. It begins to proliferate, okay? And then there's invasion of normal tissues, new blood vessels. Following that, there's metastasis. So all these pathways too are being targeted through by science to prevent further spread or further growth of the tumor. But the main things to remember here is oncogenic. Oncogenic means tumor amplification, all right? A good drug that inhibits oncogenic transmission is imatinib. Imatinib is CML, okay? So in CML, there's a translocation in chromosome 9 to 22. Because of that translocation, it kicks up a lot of proliferation of leukemic cells in the blood. So just targeting that oncogenic gene literally stops that proliferation. So that's one of the excellent things that's happened over time. We also use that target in GIST, gastrointestinal stromal tumors. And for the tumor suppressor gene, example is BRCA. BRCA gene in breast cancer. So once there's a deletion of one of those allele pairs, it triggers cancer. Now we have drugs that can prevent those things, okay? Very good. So you must understand tumor suppressor gene and oncogenic gene for your basic science. All right. So cell cycle, again, we have cells progressing, through the cycles, as I've said. The enzyme is cyclin-dependent kinase, and we've got targets for it. Cyclin-dependent kinase, that's what drives the cycle. So if you target the enzyme, you block the path, leads to cell death. Some of the terms we use, generation time is the time taken for a cell to complete one cycle. So some tumors can stack up within 3 hours. Leukemic cells can. Some tumors can stack up between 3 days and 5 days, especially testicular cancer type tumor. And some tumors generally can stack up between 3 and 30 days, small cell lung cancer. And then some tumors can stack up. In fact, most cancers, breast, colon, lung, they usually stack up about 30 to 90 days. So that gives us time to discuss them in the MDT. But these are in the context of research, not in real life. So it's just for your awareness. So there's no panic sometimes when we're investigating them because they may not have doubles, okay? They may not have doubles, okay? Tumor with high growth fractions are very, fast growing tumors are more susceptible to chemotherapy as a principle. Examples are lymphomas, leukemias, small cell cancer, testicular cancer. So the more a tumor proliferates, the more they respond to treatment compared to poorly proliferating tumors like sarcomas. Sarcomas are more solid type tumors in the mesenchymal tissue, in your muscles and bones. They don't proliferate as much, okay? But you must know the ones that proliferate faster, leukemias, lymphomas, and all that. Okay, there are some terms which, as IMT, you should know. Should you see the letter? So you can also engage with the patient. Some treatments are termed induction treatments, where we're not really sure what way to go. We want to test the biology of the tumor up front to see where we go from there. Consolidation treatments are after we've treated, and sometimes we want to maintain some form of low-grade treatment over time. We find that in hematologic malignancies and sometimes in solid tumors, okay? And sometimes there's intensified treatments where you need higher doses. It's called high-dose chemotherapy, where you may need stem cell transplant and autologous or autologous transfusion of the stem cell. So we harvest the stem cell out of the body and treat patients with high-dose chemotherapy. So those are called highly intensive chemotherapy regime. Of course, we have maintenance therapy options for patients as well on the long term, especially for targeted treatments that control the genes. Now, it's very important that you understand these terms, adjuvant treatments. Adjuvant treatments are given to patients after surgery. And the goal of adjuvant treatment is to prolong survival, one. The secondary gain is to reduce recurrence. But how would you feel that you had a breast cancer surgery or you had a brain tumor and they told you that you would die in 12 months? But if you had adjuvant treatment, you could live for 2 years. Would you still have adjuvant treatment if you were told that it may prevent recurrence, but you still die at 1 year after your brain surgery? Would you have the treatment?
Yeah.
You have the treatment, isn't it?
Yeah.
Because it will prolong your life. But if it was not going to prolong your life, would you have the treatment?
No.
No. So the goal of adjuvant treatment is to prolong life. You'll be asked these questions, for some of you doing exams, okay? So preventing recurrence is a secondary gain. If you prevented recurrence and you still died after surgery like ripples, what is the point having chemotherapy for 6 months? You get it? So the goal of adjuvant chemotherapy is towards prolonged life, and the secondary gain is to prevent recurrence and all that. But you couldn't preach to somebody who's going to cause you recurrence and you still die. What is the point treating them, isn't it? Neoadjuvant treatments are treatment given before surgery. The goal of neoadjuvant treatment is to shrink these tumors to make them operable, okay? So we say cytoreduction of the primary tumor because the surgeon doesn't have access. Either there's a vessel touching, or there's something like the heart, the atrium touching, or the bladder touching the urethra or something like that. So sometimes you need chemotherapy to shrink these tumors to allow surgery to happen. So the goal of neoadjuvant treatment is to what? Reduce the primary tumor, all right? Palliative treatment, we've talked about that. I'm not going to waste my time there. What is the goal of palliative chemotherapy? Anybody? What is the primary goal of palliative treatment? Anybody? Prolonged life, overall survival, is not symptom control. Symptom control is a secondary gain of palliative treatment. Then salvage treatment is where we use for potentially curing. That's more in hematology. So that's, because these cells can stack up a lot. After you've flushed or killed most of those leukemic cells, they could relapse early. So they need this, so they go into salvage treatment. Okay, a quick run through into the chemotherapeutic agents. All right, we have Achillate. Now we are entering the main talk a little bit now, so you have to be a little bit alert. All right, so there are many classes of cancer chemotherapy agents, and I must say some of you, did you ask some of this in your exams? Okay, they do ask some of this, so be careful to pick up the important things that I'll be talking about. Alkylating agents, taxanes, topoisomerase, platinums, anthracyclines, antimetabolites, tubulins, and all that. Let's start from the alkylating agents. The examples there we've seen, nitrogen musters, cyclophosphamide, and all that, okay? They were the first group to be seen, okay? So the way they work is usually reflected by their mechanism of action, and toxicity depends on many factors. We are actually limited by what we call dose limiting factor. Dose limiting factor is because the patient cannot tolerate a certain level of dose. So you have to reduce it. And then you may not be able to even kill the tumor as much because their toxicity tolerance is a factor. So it's one of the challenges using cytotoxic. You need to look at the dose limiting factor of the patient tolerating the treatment to adjust the dose. So patient factors, disease factor, toxicity, not always a class effect, okay? And the proper way to use chemotherapy is combination rather than single. Some of you writing exams, combination therapy is better rather than single. Combination is more effective. It also reduces resistance. Because sometimes you're treating with one class of drug, the cancer lends its way around through another mechanism of action. Okay? So it's good for you to know this as well. Okay. So there are toxicities that you will expect there, okay? Neutropenia, mucositis, and all that. These are more general, more general. For young patients, we do get sterility and infertility, sperm banking for them, okay? And we use the common toxicity criteria grading system to assess toxicity. You can find this online. We really grade them. 0 means not much of an effect. 1 means, okay, bearable, mild. 2 means, some discomfort and all that, but not requiring hospitalization. 3 means they are being hospitalized because of toxicity. And 4 means it's life-threatening. Okay? So myelosuppression, again, is something for you to be aware of, okay? The half-life of neutrophils, who knows? Half-life of neutrophils is about 3 to 4 hours, so they get squashed easily. Okay, and the nadir for neutrophils when they treat them with cancer chemotherapy is between 7 to 10 days. So patients can come into A&E within a week or over a week, I'll say, with neutropenic sepsis. Okay, with neutropenic sepsis. So the neutrophils will have dropped significantly post-treatment. So you need to be aware. So when you're clocking cancer patients, you need to check when they last had chemotherapy. If it's falling after a week and they are with you there, suspect neutropenic sepsis and start to treat as appropriate. So timing is crucial. For platelets, it's about 10 to 14 days. In fact, day 14, by 2 weeks, the platelets could plummet. The red cells, the half-life of your red cells is about 120 days. So they are the last to drop. Should they drop in the circumstances of within a few weeks to months, you could suspect pancytopenia with other causes, and it's usually severe. And sometimes that could be marrow involvement, but it's very rare for your HP to just drop with few cycles of chemotherapy. So the earliest to drop is your neutrophils, okay? Right. Nausea, vomiting again is another thing to expect. We have some drugs. Some of you, if you've done oncology or if you worked in our A&E, the chemotherapy triggers a lot of, enterochromaffin cells that are released. So we have serotonin and 5-HT receptors. These are substances that are released in your gut when you're exposed to cytotoxic agents and radiation. So you have 5-HT receptors all wake up and are releasing serotonin, okay? So we have drugs that block them. They're called 5-HT antagonists, like your ondansetron and palacitron. So they are 5-HT antagonists. And there are drugs as well that target the neutral-kinase NK1 receptors in the brain. They are called aprepitants, okay? They are very effective as well, okay? Ondansetron can inhibit on NK1 receptors, but not as a aprepitant. And the dopamine receptors, things like cyclizine, metoclopramide, and all that, domperidone, can look after those group of patients. Okay, so domperidone, metoclopramide for the dopamine receptor. So these are all released in the bowels. Okay, and then they now send a signal to your brain, and that's why you salivate and feel sick and all that. All right. So when you treat them properly, you should be able to prevent those nausea and vomiting-like symptoms, which is a common complication. Okay. So 5-HT receptor antagonists, ondansetron, NK1 receptor aprepitant, for dopamine receptors, metoclopramide, domperidone, and cyclizine. Cyclizine is also good for motion sickness as well in this patient group. Okay, so let's go back to our cytotoxic group quickly. So for our cytotoxic group, we have alkylating agents. So, I mean, it's so simple to know. Alkylating agent, literally, the acyl group in this chemotherapeutic agents, they bind to the deoxyribonucleic acid segment of your DNA, okay? This is your, you can see it there, okay? So they bind to this. This is a deoxyribonucleic, the nucleotide chain. So they bind there by alkylating it. And the normal bond here is a water bond. It's a H2O bond, normal in real life. But when you alkylate them, it's a covalent bond and it's stronger. Okay? So alkylating agent literally alkylates the cytosine, guanine, or adenine thymine deoxyribonucleic bond, which is a water-based hydrogen bond normally. Now, when you alkylate it with an alkylating agent, the DNA finds it difficult to wriggle around after synthesis. Do you know what I mean? They break up easily. And synthesis, the process of DNA replication and synthesis, is greatly affected because of that, because it's a stronger bond. All right? So the DNA cannot unwind itself and breaks into pieces at that stage as well. So the highly effective drugs that restrict the DNA by binding to them with their acyl groups. So the alkylating agent replacing the normal water bond, okay? The H2O bond. Examples of drugs in this group is cyclophosphamide, chlorambucil, and mephalan, all right? And there are bifunctional ones as well. So side effects of these alkylating agents, cyclophosphamide is highly implicated in what we call hemorrhagic cystitis. It could cause your bladder to bleed a lot, okay? So, and the antidote drug for that is Mmeka. And then we also have ifosfamide, which causes encephalopathy. We also have methylene blue ready when we give patients this drug. Ifosfamide, encephalopathy, cyclophosphamide, hemorrhagic cystitis, bleeding, okay? And these drugs are also highly implicated to cause secondary malignancies in about 10 to 15 years' time. You see some breast cancer patients after treatment, they tell you that, oh, there's another cancer somewhere. So it takes up to 10 to 15 years for secondary malignancies to show up. So that's about it for the alkylating agents and the way they act, okay? The platinum compounds, very strong group. They are very, very top drugs. Cisplatin, carplatin, oxaliplatin. These are metallic type alkylating agents. That's how to remember them. And what do? They form kind of the same way, but they are more metallic type of bond, cross-link bonds with those deoxyribonucleic bonds here that you saw. So they form DNA adducts, as we call them. And with that, they block transcription and translation. So it is quite heavy. It shatters the cells significantly. You must be very fit to receive the platinum group. So the bond is like a metallic type alkylation. It is stronger. Cell death, cell kill is very high. You must be very fit to receive it. And what are the side effects of this platinum group? They are very toxic to the nerves, neurotoxicity. They're very toxic to your eardrums, ototoxicity. And they're very toxic to your kidneys. Ototoxicity, nephrotoxicity, neurotoxicity, you get them with the platinum. Carboplatin spares you from some of the blood dyscrasias and neurotoxicity. Oxaliplatin, you still get some peripheral neuropathy. But the worst of them is cisplatin, okay? Cisplatin, neurotoxicity, ototoxicity, and nephrotoxicity. So in case you meet such patients in the A&E, is to anticipate early, okay? You anticipate early that this guy may need hydration. The kidneys are off, you have the platinum. You will ask for questions in your MRCP, for sure, okay? You must recognize platinum, okay, and know what to do. They are very nephrotoxic and neurotoxic. Okay, so we talk two groups now. The third group is the anti-metabolites. It's very simple. What they do, the DNA feeds on folates, processed folates to survive. The anti-metabolites like methotrexate, which you use in your rheumatoid arthritis, and 5-FU that we have in capecitabine and also cytosine, they literally block that path that the DNA survives, that folate pathway. They block it and starve the DNA from having that substrate of folate substances to feed. That's why they are called anti-metabolites. They prevent DNA metabolism. And the cornerstone of DNA metabolism is folinic acid, okay? Or folates, per se, processed folates. And they masquerade the purines and the pyrimidates to prevent these substances from becoming incorporated into the DNA during the synthetic phase. All right. So the normal, feed cycles for the DNA are the purines and pyrimidates, but because of the antimetabolites, they are replaced. So the DNA dies because of this during the synthetic phase. All right. So they inhibit this path, leading to cell death. Examples are 5-FU. We use it a lot in oncology, capecitabine, cytarabine, gemcitabine, hydroxyurea, methotrexate, which you have in rheumatoid arthritis. So they are anti-metabolites, suffocating the folate, the folic acid pathway. So for those of you that want to be interested, I wouldn't want to waste much time. The processed DNA feed or metabolite for this is tetrahydrofolinate. So what 5-FU does, or methotrexate, is like they block the process of converting dihydrofolate into tetrahydrofolate. And they block it through this enzyme here, thymidylate synthase. So thymidylate synthase is the enzyme that is blocked, and it prevents the conversion to processed folate, which the DNA needs. Patients can often feel very doom and gloom. So we normally give them folinic acid as a rescue. Otherwise, patients might feel as if they are dying, because the normal DNA cells too, they are starving. They are starving to death. So we need to give them folinic acid or folinate to survive them, okay? Patients can actually collapse if they are not given. So you must be aware of it. And even for those on methotrexate, they go home with 5 milligrams of folic acid, isn't it? Yeah. As part of their regime. So that's why they are having it. Otherwise, normal cells can collapse, all right? Side effects of methotrexate, you could get pneumonitis, you could get raised LFTs from methotrexate, just to make you aware. And also, your kidney function as well could be impaired. So those are the things you watch out for patients on methotrexate. And also, you could get bad mucositis from them. For 5-FU, they cause a lot of diarrhea, and they could be cardiotoxic. It could cause arrhythmias and vasospasms in about 1 in 200 of the population. Okay, so 5-FU is diarrhea, and cardiac-related problems, arrhythmia. But it's not common, but it's not impossible. But it's good for you to be aware if they're having chest pain in the A&E or casualty. Another group is called the plant alkaloids, okay? The plant alkaloids, vincristine, vinblastine, taxane. So this group acts on the M1 phase, the mitotic phase. They prevent the assembly or disassembly of the cells in the M1 phase. So after the cells have synthesized and replicated and they now come to the center, now they want to divide into mature haploid cells from a diploid state. So these drugs prevent the cells from migrating along the spindle fibers. So they arrest them there. So the simple way to remember, they prevent the assembly. Sometimes the haploid cells are the end of the poles. They want to migrate from the spindle to the center. It prevents them. And sometimes they've assembled, it prevents them from dividing. Do you know what I mean? So they die in that phase. Okay? So what do? They poison your spindle. The spindle is the channel with which these haploid cells and diploid cells travel. So the plant alkaloids like vincristine, vinblastine, we use them in lung cancer and even in breast cancer as well. Docetaxel, we use them in prostate cancer. They prevent the assembly or disassembly of the cells in M1 phase. M1 phase. It's good to remember that M1 phase and the mitotic phase. And now we've got some antibiotics that we don't use in regular times, okay? They're called tumor antibiotics, in high dose level. These drugs are used in destroying cancer cells, adriamycin, epirubicin, and bleomycin. What do? They literally cause double-strand breaks of DNA. How? So the DNA, the whole framework of it is like you're pouring it on it. It like bakes it. So they what we call intercalates. They bake the DNA, and the DNA is like a solid organ. No wriggling, no movement. So they are arrested there and they die. Cell kill can be very high with this group of drugs. So it's like a baking, you just pour a baking, something that will bake the DNA. That's what they do, okay? So it's called intercalation, so like to chelate, okay? So that's the word you may find. It intercalates those double strands of DNA and prevents replication. Intercalation, tumor antibiotics. Side effects of these tumor antibiotics, adriamycin, they are very cardiotoxic. They are very what? Cardiotoxic. Okay, doxorubicin, very cardiotoxic. Epirubicin, very cardiotoxic. Bleomycin, not as cardiotoxic, but can cause pulmonary fibrosis. Pulmonary fibrosis. Bleomycin, pulmonary fibrosis. Remember, tumor antibiotics or anthracyclines, as we call them, can cause cardiotoxicity. You need to check them out with echo. Be very careful using this on elderlies as well, okay? And we talked about their side effects, okay? Podophytotoxins, these are gotten from the trees on the back of trees, but they work a bit differently. Etoposide, tenoposide, what do? The DNA is like a zip. So the enzyme that runs this zip, once this enzyme runs on the DNA zip like that, it opens it up so that the cells that have been synthesized will replicate. Your mRNA slice will jump out of it, okay? So what that enzyme does, it runs like a grease on those DNA buttons or DNA zip every day, every minute, very fast. Sometimes we should get some more visual aids to show you how these things work in real life. There's some AI-generated image, the way it works. It's like a grease. It's going back and forth. Topoisomerase 1 enzyme. Now, what these drugs do, they block that grease effect so that the DNA is the DNA cannot unwind anymore because this enzyme is blocked, and then the cell starts to shatter. It's like open the button of your suit or shirt without opening the buttons. The buttons are arrested. They are stuck. Maybe your jacket, when your jacket gets stuck, you can't move. That's the way it works. So the DNA gets stuck there and they die because of that. So that's the way it works. The cell kill is very high for etoposide, very high cell kill. It's been implicated for secondary malignancy, and they're extremely neutropenic. Neutropenia. You have to use GCSF if you are using this regime because it literally locks the cell. Literally. It's very, very effective, especially for rapidly proliferating cancers. So topoisomerase inhibitors, that's the way it works, the podophytotoxins. I don't want to waste much of your time on that, except you come into subspecialty, but it's to bring you to that understanding, okay? So we've got the hormonals, okay, because of time. Hormonals are used in breast cancer, tamoxifen as an anti-estrogen. Tamoxifen has a dual activity. It primarily works as an antagonist of estrogen receptors. Estrogen receptors are distributed in the brain, the breast, the lungs, the bones, and most parts of the body, the liver. So the antagonistic effect on the ER receptor is used in treating patients with breast cancer. But unfortunately, it has a partial agonistic effect on the uterus, and this can cause endometrial hyperplasia in these patients. So patients on tamoxifen, they undergo yearly uteroscopy to have a look so that it doesn't proliferate, because if it goes on for many years, it could transform to cancer or endometrial bleeding, unfortunately, because of that partial agonistic effect. So tamoxifen has a dual mechanism of action, primarily antagonistic and partially agonistic on the uterus. Aromatase inhibitors, letrozole and anastrozole, they literally block the adrenocortical axis. That's the way they work to prevent the metabolism of estrogen, because breast cancer is an estrogen-driven tumor. Estrogen is primarily produced where? In the ovaries, isn't it? But in postmenopausal women, where is it produced? It's produced in the skin, the body, and all that, and also in the adrenal axis. In fact, majorly the adrenal. So these drugs are indicated for postmenopausal women compared to tamoxifen, that is indicated for premenopausal women. But it does not mean you cannot use tamoxifen in the postmenopausal. But I'll be careful for your level, it'll be premenopausal. But for postmenopausal, the better choice would be anastrozole, because your estrogen is now produced in the adrenals rather than the ovaries, okay? Anti-testosterone drug we use for prostate cancer, they literally block the conversion of testosterone. Prostate cancer is a hormone-driven cancer whereby testosterone proliferates. So we've got drugs there, biculantamide, finasteride, and all that. And we've got the leuprolide prostat that they get 3 monthly for their prostate cancer. So it literally blocks the FSH-LH axis. That's what it does. And once it blocks that, there's a paradoxical release again of FSH-LH that causes flushing peripherally in this patient group. So because of that positive or negative feedback effect, patients are put on biculantamide for 6 weeks, about 4 weeks, to prevent those peripheral effects. And of course, steroids, we use them a lot. Steroids are very multi-purpose, from nausea and vomiting to inflammation to a lot of things in cancer. They primarily work through the interleukin. In fact, I'll say interleukin 6 pathway. That's where your steroids work, okay? They're very kind of pro-cytokine. So they reduce the outpouring of these interleukins, and they reduce inflammation, edema, and all that. But their function can be generally non-specific, but it's through the interleukin pathway 6, interleukin 6, interleukin 10. Your interleukin 1 is where your paracetamol works and things like that, and your nitric oxide pathway. So dexamethasone can be quite potent. It can be a painkiller as well, anti-nausea, anti-that, because of that action of interleukin pathway. Okay, there are some cell cycle specific drugs. I don't want to trouble you with this. I'll leave it for the postgraduate student, but if you want to know about the cell cycle, when it says specific, that means it works on the synthetic phase. Examples is 5-FU, and there are non-specific ones like cyclophosphamide, okay? And then we have steroids as well that act in every direction, not really specific to any part. I'm not going to trouble you with this because of time. So specific phase, M1 phase, we've talked about it, Mmeka alkaloids, okay? They stop the arrest of cells in the M1 phase. Synthetic phase, capecitabine, 5-FU, methotrexate, and all that. So we use radiotherapy as well in synergy with chemotherapy to control cancer. So this partial representation helps a lot to control cancer cells. And of course, we've got chemoradiotherapy. So chemoradiotherapy is a way to treat, where we use chemotherapy to enhance the effect of radiotherapy to kill cells, just to let you aware of that, okay? So there's a spatial cooperation with it there. So we've talked about radiotherapy and chemotherapy. Other ways we treat these days is through targeted treatment, where we target the genes that drive the drug. That is the age of precision medicine or targeted medicine per se, okay? So we use the genes of some of these drugs, okay, that these patients carry, and tease it out and target those genes that drive the cancer. I've already talked about the 9 to 22 translocation in CNL, okay? The drug of target there is imatinib, so it prevents that upregulation. We have anti-VEGF drugs that cut off blood supply. The RAS and the BRAF, we have about 50% of patients with colon cancer carry the RAS gene. Should we block that gene, we regulate the pathway, and cancer is better controlled because of these targets, okay? So we could go on and on, but this is another part which I would want to waste much of the time here. But there's EGFR, we have it in lung cancer, we have HER2 expression, about 20% in breast cancer, and then we have the CMET in lung cancer. So all this part, mTOR, PIK3, these are all potential targets, okay? So this is the cell, this is the DNA. I don't know whether you can see me there. This is the DNA, all right? This is the DNA of the cell. This is the intracellular domain or cytoplasm, and this is the extracellular domain of the cell. So at the cytoplasmic membrane here, you begin to see those EGFR. The targets that are underneath it, they are called the small tyrosine kinase molecule targets. And the ones on the outside are more bigger molecules in the extracellular domain. And this is what we call the mitogen activation pathway, that once these cells are triggered here, they send down signals to the DNA right here, leading to what, cell proliferation, apoptosis, and all that. So these are all potential targets now in science, which I wouldn't want to waste much of your time, but most of the drugs you hear, they target some of these mutations. Like this is ARC, we've got this one in lung cancer as well. So I could go on and on here. We're not going to exhaust it because of time. So imatinib we've talked about, you may want to remember that in CML, translocation at chromosome 922 gene, okay? So that's an oncogenic transformation, but it blocks that stacking up of cancer cells. Cetuximab we use in colon cancer, it blocks the RAS gene, in the EGFR membrane. Bevacizumab cuts off blood supplies and anti-VEGF, all right? Tarceva, small tyrosine kinase inhibitors. I don't want to waste much of your time there. For immunotherapy, that's the cutting edge treatment for today. Immunotherapy literally upregulates the immune cells to treat cancer through your T cell pathway. We have the CD4 and CD8. The CD8 are your cytotoxic cells. So what the cells do, so we now learned in the last couple of years that if we upregulated the immune system, we can actually treat cancer cells. So it's now where the technology is, where the immune cells are upregulated to treat cancer. We also have passive immunity. Passive immunity you get here, whereby things like BCG or interleukins are infused into patients, like in bladder cancer, to treat disease. So you're getting their immune cells from another person that has been infected with the cancer and now transfuse it to another person that has the cancer. So that's passive immunity, okay? But active immunotherapy is where we are at the moment. I know it's becoming too much, but it's good for you to understand the era, because these are where the big part is now. We have the PDL1, okay, and the PD1. So literally, the PDL1 is on the tumor cell, and the PD1 is on the T cell. So this PD1 and PDL1, they literally uncap or cover the cancer cells. So they are like the safety mechanism of the body so that you will not stimulate too much T cells. The PDL1 is on the tumor cell and the PD1 is on the T cell. So anytime there's an antigen, a tumor antigen presenting cell, as you see right here, okay, there must be a response from the T cells. So the PD1 comes to say, okay, that's all right, like a break to your immune cells. So this new immunotherapy, they take away that break from your immune cells. So they cap the PD-1 or cap the anti-PD-L1 so that the cells cannot recognize it and they keep firing. So you keep firing out your immune cells because the brakes have been taken off your immune pathway. So that is the technology behind it. So the PD-L1 is on the tumor cell and the PD-1 is on the T cell itself. So once you take off the brake of your immune cells by uncapping this PD-1, the cells continually fire, as you see here. So once you cap them through those monoclonal antibodies, like pembrolizumab or nivolumab, the cells continue to fire to kill the T cells. The same thing on the PD-L1. Once it's blocked here, once it's blocked, the cell cannot evade itself. So it's exposed continuously to T cells. Okay, right. The same thing in your CTLA4 inhibitor. I don't want to trouble you too much with that, but that's B7 co-stimulatory cells that is blocked again by an anti-CTLA4 called ipilimumab. So that's where the technology is now, by taking off the brakes of those PD-L1 and PD-1 and exposing the cells to continuous exposure to T cells, okay? Immunotherapy can affect literally any part of the body, just to make you aware, from your eyes to your lungs to your liver to your GI tracts, everywhere, and it could be time dependent. I wouldn't want to go into that because of time, okay? But it's for you to be aware. But the common side effects are rash, colitis, raised LFTs, and endocrinopathies, especially your thyroid function tests, okay? Things like hypophysitis can be late. It can take up to a year before you get that, but it's not impossible to be early. All right, so you have to be aware of those immunotherapy related, okay? Diarrhea, shortness of breath too, pneumonitis can be common with these drugs as well. So keep an eye on that, and endocrine symptoms and all that, okay? And of course, raised LFTs leading to hepatotoxicity, skin rashes and all that, okay? So always liaise with your acute oncology team early if you find these patients, okay? Don't be bold. If you're in the A&E, liaise with them. Do your basic workup, but please include your cortisol levels, okay? Include your cortisol levels, please, okay? Very, very important. And also involve appropriate specialist team, respiratory or gastro early as well. Don't buy the bull on yourself trying to do this job all on your own. Get them in. Steroids we use as soon as possible if it's confirmed that it's immune related. Mycophenolate is used for those with liver toxicity and then infliximab is used generally for those that are steroid refractory. If they are refractory on steroids, infliximab is the next best thing. And mycophenolate, if they are refractory on steroids, for those with liver disease, it's the better because infliximab is not so safe with liver toxicity, okay? And of course, you do your serology. And also, sometimes, it's very difficult. It could be PCP or pneumocystis jirovecii. So put them on cotrimoxazole or acyclovir or fluconazole. So you need to rule out these differentials too when you're looking after these patients, okay? So that's about immunotherapy. In chemotherapy, generally, we treat intravenously, oral, intrathecal, intrapericardial. We treat literally even lymphofusions, intraarterial, intraperitoneal. So we do a lot of crazy things with chemotherapy to control cancer. We need to know their height and weight with their body surface area to get the actual dose. Of course, we factor this with the renal function, liver function, and a lot of parameters, as well as their food log count. So it's a complex process of getting it right, really, So we talked about single agent chemotherapy being better and not as effective as double agent, okay? So this one literally happens when you treat. We expect the normal cells to bounce back with the dotted line to bounce back after treatment, but you could see they get a spike as well, They are not spared either, all right? The normal cells are affected, but they should bounce back early, but not to be suppressed as much like the tumor cells, okay? Not to be suppressed as much, okay? Drugs are given in a cyclical fashion, like 3 weekly or 4 weekly, to allow normal cells to recover. We don't suffocate you in one go, okay? So that's why patients are in cycle 1, cycle 2, cycle 3, cycle 4. So we can allow normal cells to recover, okay? So they are given in cyclical fashions of 4 weekly, 3 weekly, or 6 weekly, based on the half-life of these drugs. So it's good to know what cycle these patients are at when you are looking after our patients, okay? So we've talked about the doublet being superior to single because it prevents resistance, okay? Combination therapy more superior to single agent because it prevents resistance, all right? Assessment, very important, taking factor age, medical history, and a lot of things are proper staging of the cancer. You need to be sure you've got a histology confirmed in this patient. It's not something you want to be using cytotoxic and you're not sure about, okay? You must be very sure what you're dealing with. Okay, one of our assessment tools is the ECOG performance status down below here. The ECOG performance status is so crucial. It's so crucial. 0 means the disease has not affected the patient. 1 means it has affected them. They are still up and about. 2 means it affected them, but they are in bed less than half of the day. 3 means it has affected them. They are in bed more than half of the day. 4 means they are in bed all the time. We don't treat those that are ECOG 3. You have to be the disease must be very responsive for us to treat them, okay? ECOG performance status 3, not very good candidates for chemotherapy. We also use the KPS, the Panosfi performance index score as well, which I don't want to go into because we rarely use it these days, okay? So that's your pre-chemotherapy assessments and things like that. We look at the tumor markers as well, okay? WHO is one of the response criteria we use, but for research, we use more the RECIST criteria. It's good for you to be aware of this, okay? The RECIST criteria is when you treat on radiology, you get a disappearance of the tumor in the longest diameter, less than 10 millimeter or not at all. So it is described as complete response. Partial response is when the tumor responds with at least 30% reduction in the longest diameter of the tumor. Partial response. It does not mean it's 30% alone. It could be up to 100%, but it's a simple radiologic language. So when you see it on the CT scan, it says patient has had a partial response. It means from 100% to 80%, but at minimum of 30% across the board. Okay, so that's what it means. It does not mean anything partial. It means a lot because sometimes some of the tumors are not seen. Okay, progressive disease is where there is a 20% increase in size of the longest diameter of tumor. Some tumor may not have progressed because they've not met the 20% criteria and they've not also responded on more than 30%. They are described as stable disease. So when you see a CT scan saying stable disease, they've not met this criteria. It's for your interpretations as registrars and as IMT doctors when you see these reports as well, okay? Resistance to chemotherapy could be through all sorts, gene amplification, and, resistant clones appear after a while in the journey of your cancer patients, unfortunately. Okay, just a quick reminder before we finish. Ototoxicity, platinum compounds. Secondary tumors, alkylating agents like cyclophosphamide. Cardiotoxicity, anthracyclines like doxorubicin and pyriproxine. Pulmonary toxicity, bleomycin. Bladder toxicity, cyclophosphamide. Nephrotoxicity, again, platinum compounds. Okay, and then tumor lysis syndrome, and for rapidly, we get this. Tumor lysis syndrome is actually a time-dependent definition. Okay, it occurs within 48 hours to 72 hours. Somebody presented 2 weeks, rarely, but it's not impossible to say it's tumor lysis. But the classic definition by the Royal College is 48 to 72 hours, where you get a rapid breakdown of tumor cells. You get it for very highly responsive cancers like small cell lymphomas and leukemia. It is an oncologic emergency, okay? So I think I could give you guys a break for 10 minutes and then we come back. There are loads of interactive quiz session and case-based discussion, a lot of learning to do for about 30 minutes or thereabouts. So I could give you a break for 10 minutes, then we come back for the interactive session. Okay? I can take questions for the audience online. Okay? Any questions? I'm ready to answer. Go ahead. Any questions? Any question? If not, let's take a break for 10 minutes, okay? 10 minutes, all right? Okay. So how did you find it?
I thought it was really good.
Huh?
I thought it was really good. I've got my part 2 in July, so this is very helpful.
Yes, yes. We try to tell you what you need the most.
Yeah.
Immunotherapy is the focus now for your part 2, for in the basic science. You need to understand how it works, up regulating the T cells, literally taking the break off those. The PD-1 and the PD-L1, they're your natural resistance mechanism, okay?
Yeah.
All right? They're your natural resistance mechanism, okay? So we've now taken off the brakes and the T cells keep firing, okay? You must know the PD-1 is on the T cell as a brake mechanism, and the PD-L1 is on the tumor cell. Once you get that, you will get the answer straight away. Okay, immunotherapy can affect literally every part of the body, and then those are the things. And of course, your cell cycle we do ask the mitotic ones. Side effects of methotrexate we do ask as well.
Yeah, all the other side effects as well, which you mentioned. I think
They
Dr.
do ask.
Rubinson very commonly asked.
Anthracycline, cardiotoxicity, we do ask as well. That's why I kept emphasizing them for you people. Bleomycin, we do ask as well.
Usually.
Pulmonary fibrosis, okay? Methotrexate can also cause interstitial pneumonitis and raise the LFT. Yeah, that's the group there. Okay, can you all hear us? Can you all hear us?
Yes, we can hear you.
All right, okay. So we're going to be going for the interactive session now. And as a feedback, yeah, that's it. As a feedback, yeah, that's just where we are. As a feedback, how was the last session? Somebody speak. We want to hear you talk. Huh? Okay. So let's press on. So you can hear me very well, can you? So these are more interactive sessions. So I'd like to hear you guys speaking from the floor as well. So a patient comes in having had chemotherapy and there was nephrotoxicity, a bit of hearing problem and peripheral neuropathy. Which of these drugs is likely for you to be concerned about? I want to hear somebody from the Teams meeting there online, not from the classrooms. Anybody?
Cisplatin.
Cisplatin, correct, cisplatin. Okay, very good. So cisplatin. So which of these drugs have been implicated to cause cardiotoxicity? Cardiotoxicity. Again, somebody from the online group.
A.
Option A is what? I want you to call it doxorubicin. Is that correct?
Yeah.
Exactly. So doxorubicin belongs to the anthracycline group as well. So these are very high dose tumor antibiotics. Okay, anthracycline group. Other members there are epirubicin. Okay, epirubicin, doxorubicin, anthracycline is the family. Okay, so they are heavily implicated for cardiotoxicity. Cardiotoxicity. All right. So which of these highly implicated for pulmonary fibrosis? Again, from
Bleomycin.
bleomycin. Bleomycin, correct, bleomycin. So for patients that are having treatment with bleomycin, please, any inclination of shortness of breath, get a chest x-ray, don't treat. And what's the investigation of choice for pulmonary fibrosis?
High resolution CT.
Yes, high resolution CT. So from index suspicion of shortness of breath, you should move on with a high resolution CT. Chest x-ray, then high resolution CT, okay? Thrombocytopenia, which of these drugs heavily implicated to cause thrombocytopenia? Anybody? Thrombocytopenia.
Is it B? Is it gemcitabine? Is it
No.
the one?
No. So the drug that is most notorious for it, do you know anybody here? It's carboplatin.
Oh, really?
Carboplatin, okay? Carboplatin, very notorious for thrombocytopenia on day 14. Neutropenia will be day 9 or day 7 to 10. There's no comment on that. Have we lost connection? I think maybe network or something. Okay. Okay, so carboplatin, all right? Neurotoxicity and severe constipation. Neurotoxicity and severe constipation. Anybody?
Cisplatin. Cisplatin, I think. C.
No, I wouldn't take that. Cisplatin can cause neurotoxicity, but there's a drug that is heavily implicated to cause constipation. In fact, it has a very narrow therapeutic window. We have to give only a small amount of it. Okay, let me give you a clue. It acts on the M1 phase, mitotic phase of the cell cycle.
Vincristine then.
Vincristine, okay? So is extremely neurotoxic and can cause severe constipation. So vincristine is the answer there, okay? Hemorrhagic cystitis, bleeding bladder, all red after treatment. Which of these drugs is heavily implicated for that?
Cyclophosphamide.
Cyclophosphamide, correct, cyclophosphamide. Very impressed, okay? Arrhythmias and vasospasms. Chest pain, had this drug within 2 weeks and came to A&E, ECG, chest pain. Anybody? 5-FU capecitabine. Very good. Encephalopathy, had treatment within 2 weeks. Young gentleman came in, was having history of testicular cancer, very confused, moribund looking. Ifosfamide is the answer. And what is the anecdote? What's the antidote? Methylene blue, that's the antidote. And for hemorrhagic cystitis, that we saw here, the antidote for this is Mesna, okay? Mesna. So if it happens acutely, Mesna must be around to give the patient. We usually give them prophylactically while they're on treatment, okay? And for your 5-FU, it usually occurs in the first cycle of treatment. Usually, they come in with chest pain and all that, ECG changes, all right? So you have to be aware of it. 5-FU is the infusional form, capecitabine is the tablet form, okay? So it's very notorious. The incidence about 1 in 200, but in susceptible patients, about 1 in 20. For high-risk patients, it could be up to 1 in 5 chance. It's not a contraindication not to treat, but you have to be careful with these patients, okay? You have to be very, very careful. So we talked about ifosfamide, encephalopathy, methylene blue, all right? Interstitial pneumonitis. Somebody had treatment after 6 weeks, very short of breath, chest X-ray showed interstitial changes. Which of these drugs is highly implicated to cause interstitial pneumonitis?
Docetaxel,
correct. Docetaxel. Okay, so docetaxel, what class does it belong? Anybody?
taxane,
But what's the mechanism of action?
inhibit microtubule formation.
Exactly, M1, microtubule formation. Okay, very good. Immunotherapy can cause, what's the answer here?
Colitis.
So you think it's colitis, okay?
All of the above.
All of the above is the answer, okay? So just to hinge on that, colitis, skin rash, raised LFTs, you can get these signs or symptoms or complication as early as 6 weeks to 3 months. You could get them, okay? Or even later, but you could get them early. Hypothyroidism, probably after 3 months to 6 months. Hypophysitis may be coming to 12 months or less, okay? Just to let you know. But the commonest ones are skin rash, raised LFTs, colitis. You could get this in the space of 6 weeks to 3 months or max to 6 months, okay? So all of the above is the answer, all right? Okay, what is the tumor marker for breast cancer? Anybody?
CA153.
CA153, okay? So the BRCA1 and 2 gene is not a tumor marker, it's a biomarker of breast cancer, okay? Very good. And CA19.9?
Pancreatic cancer.
Pancreatic, yeah. CA?
Colorectal.
125?
Ovarian.
Fantastic. Okay. Let me go back to the tumor marker. What is the tumor marker for classic pure seminoma of testicular cancer? You are usually asked this in your MRCP. What is the tumor marker for classic pure seminoma?
HCG.
Beta HCG. That's the answer. Yeah. It's not AFP. AFP is for non-seminoma with the mixed germ cell tumor. That is an MRCP question. Okay? So classic pure seminoma is beta HCG, but in non-seminoma mixed variety, then AFP and beta HCG can be your answer. Is that clear? Very good. Okay, sepsis. So somebody comes in with sepsis as an emergency. This is from the Acute Oncology UK nationwide guideline. 3 in, 3 out. Treat suspected neutropenia as an emergency. Start your IV fluids. Give oxygen if need be. 3 out. Take your blood cultures. Check FBC. Check your lactate levels. Okay, and then hourly urine output for some patients, if not most patients, because if they are sepsis, they could go into renal failure very quickly. But sepsis is sepsis. It's different from febrile neutropenia, okay? Febrile neutropenia means they are neutropenic with fever, but they are not septic looking in any way, and they are hemodynamically stable, all right? So antibiotics should be given before a full history. Okay, somebody has come in on day 7 to 10, day 9, is looking moribund, he had chemotherapy, start antibiotics. That's what the guideline is. Ensure first dose of antibiotic is accurately recorded. I'm telling you, this is the Royal College and the UK guidelines. If you saw it in the MRCP, it's not about going to give antibiotics. If you're asked the next best thing, the next best thing is give antibiotics. All right? That's the answer. What is the antibiotic of choice for somebody you're suspecting neutropenia? Anybody? Tazocine. Why do we give tazocine as the choice drug? Any reason? Anybody? What is the organism of concern why we give tazocine? Pseudomonas. Again, that's an MRCP question. Tazocine or piperacillin is broad spectrum, gram-positive, gram-negative, but has activity over Pseudomonas. Why are we worried about Pseudomonas? Because Pseudomonas is a hospital-acquired infection. These folks are on cannulas, they're on PICC lines, they are coming into hospital every time. In fact, there's a study that doctors, when we are older than 65, 70, we will be colonized by Pseudomonas because we've been hanging around the hospital for a long, long time. Okay? So that's why it's the drug of choice, tazocine. Is a hospital-acquired infection. Who knows other hospital-acquired bugs? Anybody? Quickly, from online group there, what are the hospital-acquired infection? We've mentioned Pseudomonas. What else?
C. diff.
Liver CDF is not, CDS is another, CDF is not necessary. You could get it anywhere. Okay, what are the hospital-acquired bugs? Okay, so the code there is KES. KES, Klebsiella, E. coli, Shigella, or Staph aureus, and then Pseudomonas, KES, okay? Is good, again, is an MRCP question. You must know the hospital-acquired infection, okay? Your Staph aureus, your Staph albus, Staph epididymis, contamination and skin, and then your Pseudomonas, Shigella, and Klebsiella, and E. coli, which we see all over the place, okay? All right, so investigation, again, you need to look at your investigations where relevant, okay? So question, what is the most common type of white blood cell? Quickly, from the online group, quickly. The most common type of white blood cell. Anybody? From the online class? I've not heard from those in Boston, the online group there. Let me hear from the Boston class, the Pilgrim class. What is the most common type of white blood cell? Those joining from Boston. It's not a hard question. If this was MRCP, to be a tragedy. Neutrophils. What is the half-life of a neutrophil? Does anybody know? Pardon?
7 to 9 days.
No, it's about 3 to 4 days, really. You know, it doubles very fast. You know, in fact, from hours at times, okay? So it's the most proliferated, even in hours, okay? What is the name? Okay, we know the name of low neutrophil count is called neutropenia, isn't it? Okay, is that correct?
Yep.
Neutropenia. When are patients most at risk of neutropenic sepsis or neutropenic fever? When?
7.
Anybody online there? Anybody online?
7 to 10 days. 7 to 10 days.
7 to 10 days, okay? So which are the following signs of sepsis? Anybody there to discuss it?
Go on mute.
Pardon? Which are the following signs of sepsis?
Low blood pressure.
Looks like everything.
Exactly. Everything there. Somebody could come in with low temperature. So having a low temperature, you could be in septic shock because cancer patients with chemotherapy, they are so immunocompromised, they are not able to mount temperature. So they could come in A&E, they are 37 and they are dying in front of you, or they are 35, 36, they are dying because they are not able to mount enough temperature response. Poor temperature response is common in children and in elderly and in the immunocompromised. So when they are not having temperature, don't wait for 38, start antibiotics. Especially when you're getting heart rate, low blood pressure and all that, they are looking unwell, okay? So all of them is an answer. That again is an MRCP question. Okay? We're going to stack all of this and say choose all.
Yeah.
Just to warn you, I will not tell you that I submit questions, but you miss it, some of these things. Which of the following will be at risk of sepsis?
Everything.
Everything. You can have mucositis, diarrhea, cough, green sputum, hypotensive features, shivering, okay? And sometimes there's no shivering as well, okay? And patient is unwell. Very good. Case study. 53-year-old lady called Judith presented in A&E with a temperature of 38.1. Judith has a history of breast cancer and received a cycle of chemotherapy 7 days ago. Observation showed all that. What would you treat this as?
Treat as neutropenic sepsis.
Okay. What are the things that are making you to treat as sepsis? Because supposing this could be febrile neutropenia. Why are you treating as sepsis? Go ahead.
This patient had chemotherapy 7 days ago, entering the neutropenic window.
And then the heart rate.
Heart rate is
and then the respiratory rate is high. What is the normal respiratory rate? What is the normal respiratory rate? Again, we will ask.
Most schools have taught 12 to 18.
Yes, the respiratory rate is just about, in fact, 8 sometimes, when 8 is low, at least 12 to 18. Okay? So when you're seeing 18 is top range, it's breathing fast, it's tachypneic, blood pressure, not desperate. But that heart rate, there's tachycardia, there's respiratory rate. Oxygen is not bad, temperature is 38, all right? But sometimes we can put the blood pressure to be very low. Once you see the blood pressure low, it's sepsis, treat as sepsis. Febrile neutropenia, the vitals will be stable, okay? And maybe temperature can still be high, okay? So you must separate those two, okay? So what would you do next? What would you do next? Somebody online. What would you do next? Do you want to contact acute oncology and get advice? Or do you want to take observation to see if there's any change? Or you want to cannulate patients with intention of administering antibiotics?
Well, the most important thing will be giving antibiotics within 1 hour of contact with the patient.
Exactly. So I've already told you guys on the guidelines, Sepsis UK. Okay, that's the next best thing. Don't go and contact acute oncology. You know, don't pass the buck. This is a basic physician thing. All right. Okay, you can contact us later. Okay, now our patient is in, but start to treat them right there. All right. Okay. Let's say that patient actually on your antibiotic choice had a PICC line infection and there was pus oozing out. And you started tazocine, the patient is not responding, he's still hypotensive, fever is not responding. What would be the next antibiotics of choice? The patient's PICC line was oozing purulent exudate.
All of them.
Pardon?
All of them.
No. What would be your next antibiotics of choice? I'm just asking. If somebody had a PICC line infection, anybody?
No. PICC line infection.
PICC line infection would be vancomycin.
Yeah, it wouldn't be Mmeka.
Yes. So vancomycin should come to your memory quickly, okay? There's certain things, don't waste your time with micro. We want you to begin to do it there. Vancomycin, or you can even use Fluclox to start, all right? You could use Fluclox to be more specific, and then you culture the tip of the PICC line and all that, start to take it out, okay? All right, so always look at the cause of the sepsis and to treat rather than being remote control to tazocine, okay? All right. If the patient was in renal failure, what would you do for your what would you do? What would be your choice? Renal failure, what's the best choice? Anybody can discuss that from online quickly.
Icoplenol?
Yeah.
Well, you can use meropenem or teicoplanin, but again, you can give a renal dose of tazocine. Okay, in renal failure, all right? You can give a renal dose of tazocine, all right? But let's say it's so desperate. Would you add gentamicin or would you use, what other drug can you use in renal failure to help as a choice drug? While you're having your tazocine, but you're worried of patient not being stabilized and there's renal failure. Is there any other drug you can use? Ciprofloxacin. So ciprofloxacin is renal friendly, okay? So if you don't want to cause more renal toxicity, you can avoid gentamicin and add ciprofloxacin. Ciprofloxacin is a gram positive or gram negative cover. It's very gram negative. It's very gram negative. Gentamicin, is gentamicin gram positive or gram negative?
Gram negative.
Gram negative. So that's why ciprofloxacin is a good choice. If the patient was penicillin allergic, what would you do at that point? First choice. Penicillin allergic. What's your first choice then? Somebody quick, huh?
Carbapenems.
Carbapenem is a choice, yes, meropenem or astronam. They are penicillins, but the incidence of cross-reactivity is about 1 in 300. So the chance of it happening is very low. What other penicillins could you have used? Cephalosporins, okay? But cephalosporins have a 10%. Okay? All right. Okay, so let's move on with this. So blood tests are now required. You've done full blood count, LFTs, C-reactives. What else can you add to the bloods at this stage? Number 8.
All of the above.
All of the above, yeah. You could do blood cultures, but still from clinical grounds, you need to watch your patients. You don't have to do venous blood gas if they are not too bad, okay? But in sepsis, if they're not looking good, you need to start to move around. But blood culture is very, if the question was, what is your next best thing, okay? Make sure blood culture you took. Lactate goes alongside as well, okay? All right, but the rest is okay. But don't go and worry yourself with blood glucose. All right, so you must be more specific. So the next best thing, make sure there's a blood culture done with your lactate. And if patient is hemodynamically unstable, you can do your blood gases and all that. Okay, very good. So what should you ensure happens within 1 hour? I think somebody has said it today. What should you ensure happens within 1 hour? Make sure IV antibiotics is done. Again, within 1 hour or two, if you stabilize your patient, you can still contact acute oncology. Okay? Okay. Would you obtain an infection screen? What would you obtain in an infection screen? Anybody online? All of them, isn't it? Okay. Okay. In a urine sample, what is the most diagnostic there? Is it leukocytes or nitrites or protein? What is most
Leukocytes
diagnostic?
and nitrate.
Which one is most diagnostic? Is it leukocytes or nitrites or protein? Again, these are questions we ask as well, you know? So you need to check that out. Which is most diagnostic there? Nitrites. Okay? Nitrites. Because sometimes you're going to see a lot of answer in your MRCP. There's hemolytic uremic syndrome. There's thrombocytopenic purpura. There's henoscolen purpura. There's a lot of renal syndrome for you acutely to manage. Okay? So you need to, once there is nitrites and all those information, it could be just urinary tract, and you're sold away there is HUS or this and that. Okay? So nitrites is very specific that there is a urinary tract infection because the bacteria has broken down those cells. White cells could be non-specific at times. Okay? They could be. But yes, it normally goes hand in hand, nitrites and white cells. Okay? Very good. Would you admit this patient? Okay, so for certain you will admit this patient, okay?
Yes.
Yes. If the patient had febrile neutropenia, was watching a match at home, a Manchester United match, and then the neutrophils were 0.5, and the patient rang the helpline or rang the A&E doctors, would you bring the patient in? The patient was hemodynamically stable, neutrophils was 0.5.
Yeah.
Yes.
The patient was okay at home. Would you bring them in? The patient was okay. Was okay. Just reported that they just spiked the temperature, but they are fine. They are watching TV at home. Would you bring them in?
I mean, yeah, I'll bring them in.
Okay. Okay.
Because
why?
we already said there are 7 days post chemotherapy. Okay, you already said neutrophils of 0.5.
Yeah.
I would rather prefer a physical assessment of the patients, as much as I know that there's a tendency for them to be managed in an outpatient. But we know that neutrophils will not quickly recover by itself. So sometimes they might need support for the neutrophils.
Yeah.
So I
Well,
would
it's
rather
not wrong
prefer
to bring them in, but it's not absolute that you have to admit them.
Mm.
Okay, that's what I'm trying to say. Because they could go home and the neutrophil starts to recover. And sometimes it could drop further. But if they are well, we keep them home. You can give them prophylactic antibiotics at that time, ciprofloxacin. Even right now, we're trying to network where we're treating them away and out of hospital as much as possible. Neutropenia is not a bad sign. It's actually a complication of chemotherapy. It actually shows that things are working, but it's a complication of treatment, okay? So if they are well and doing fine, they can stay at home. But they come into hospital, we reward them with MRSA and CDF, and sometimes they now go with more problems, okay? So it's not impossible that febrile neutropenia can be managed at home, okay? All right, very good. 12, if sepsis is suspected with infection in the central line, what should you do? What's the answer there?
There doesn't look to me like a correct answer there. We should rather avoid the infected line and give peripherally. If we want to do a lock, an antibiotic lock, fair enough, after speaking with microbiology, maybe a gentamicin lock if we want to. But an infected line, I don't think that will be our first thing.
What is the best thing to do for an infected line?
Take it out.
Take it out.
Take it out. So it's a discussion of something. We don't have to put the answer. So again, we could frame these questions for you. Take it out. All those things are just boggling your mind. None of them, Blanche, is correct. None of them is correct. Take it out. It's infected line. Don't. So the best answer is take it out. You can call oncology and give your antibiotics peripherally. Take it out. It's bad. And that's the central line. You're faffing around with infection. So take it out. All right. Very good. Very good. I think because we lost some time, I don't want to show you more slides of toxicity. I've concentrated more on what you need, okay? I've concentrated more on what you need, literally. I would like to take questions where necessary and feedback, okay? Anybody? Anybody? Did you take something out of this lecture? Let me hear from the online guys. Hello? People are not speaking. Okay, let me ask you, did you take something from this?
Yes, definitely.
What were the high points from the lecture initially?
I thought, I mean,
Speak up.
mainly from like an exam perspective, but also like from a clinical aspect. First thing was about palliative chemotherapy, that it's used to prolong survival. And also that, if they're just on palliative chemotherapy, you should think twice before just putting them DNA CPR. I thought that was important because I've seen that quite a lot when I'm on the take as well. And then adjuvant therapy is also used to prolong survival. And I think most importantly, from an exam perspective, I think complications of the chemotherapy agents, I think that was really helpful. And like with cycle, they sort of like attack as well. I think from an exam perspective, that was like very helpful. Yeah.
Okay, that's very good. Okay, very good. Okay, anybody else? So she said from an exam perspective, she took out a few things from cell cycle to some of those definitions and stuff like that, okay, for our exams, that it was quite helpful. And of course, understanding the mechanism of action as well of those drugs and some of their side effects, okay? Okay, yes, anybody else? Anybody else?
Yeah, from a practical wise, 2 points. One, when we are asked if the clerk patient was likely neutropenic sepsis, we just had a cycle of chemotherapy, about the timing of the sessions and what we should do first as the first thing in the management. And also when we are paged by the oncology ward with a patient on one of the chemotherapy agents and just having a side effect or just had his cycle and is experiences what could be tumor lysis syndrome and the time frame of it. So this is a 2-point practically from this session. Okay,
well, that's good to know as well. That's just good to know those practical aspects of what to do. Difficult one now. I just want to share. Do you people have more time, or you think you're okay for the day? Okay, I just want to share this slide quickly before I go. Oh my God, I don't know. Okay, can you see this? Can you all see this? You can. Okay, For those of you who have time anyway, from the beginning. Can you see this? Okay. 32-year-old man with testicular cancer completed 3 cycles of chemotherapy with bleomycin, etoposide, and cisplatin 3 months ago. He presents with a complaint of exertional dyspnea of recent onset. Chest X-ray shows, oh my God, this is chest X-ray. You can see pulmonary fibrosis, isn't it? On this, that's a high resolution scan. So what do you think the answer is? Are you happy with this?
Yeah.
What drug do you think could have caused this?
Bleomycin.
Bleomycin. Very good. Okay. So that's a high resolution CT there. 62-year-old man with colorectal cancer, capsaicin oxaliplatin treatment, has pain, redness, numbness, desquamation of the hands. What is the most likely diagnosis here? Well, these are more exactly, yeah. So it's palmoplantar erythema, okay, redness of the hands and feet. Now, these are for those of you writing on MRCP UK specialty certificate exam. That's when these ones become relevant because they are deeper. So you must have been in oncology posting to pick this up, okay? That's how it is. Look, can you see how it is? So they get redness of the hands, all right? They get redness of the hands, okay? Okay, 55-year-old with a positive hormone receptor breast cancer has been on zoledronic acid for a couple of years, presented with jaw pain and maxillary swelling. Okay, what do you think could be going on there?
Osteonecrosis of the jaw.
Exactly. And which of the drugs are heavily implicated there?
Zoledronic acid.
Zoledronic acid, okay? So we normally want them to get a dental checkup or an OPJ, all right? So again, we can ask this in MRCP because it falls within general medicine belt, okay? So it's osteonecrosis of the jaw. Okay, that's osteonecrosis there. It can be so bad, and that's your OPJ, all right? You can also do MRI of the jaw. Again, we do ask it in MRCP, okay? For your MRCP, we could show you this and that and all that, okay? Okay, 19-year-old, again, this is an MRCP question, okay? 19-year-old woman presenting worsening bilateral heat pain for the past months, acute lymphoblastic leukemia, undergoing maintenance chemotherapy every 3 months, vincristine, prednisolone, and all that. What is the most likely cause of the bilateral heat pain? Anybody?
AVN.
Avascular necrosis. Avascular necrosis.
I'm very glad people got that, okay? Very important. And what could be causing that?
Prednisolone.
Again, that's an MRCP question, okay? Okay, that's an MRCP question. Have you asked it before?
Yeah.
You seem to be nodding, yeah. So a vascular necrosis does steroids. Long-term use of steroids can give you a vascular necrosis. In oncology, we use steroids a lot. So you have to bear that in mind, okay? And what's the investigation of choice?
MRI.
So that's the MRI there, okay? All right. 40-year-old man, metastatic colorectal cancer, 5FU, oral pain, difficulty swallowing. What do you think the diagnosis is? Physical examination of his oral cavity is shown, although that'll be the next slide. What do you think this diagnosis might be?
Mucositis.
Yes, they can have mucositis from 5FU as a complication. Most of those anti-metabolites, methotrexates, 5FU can cause mucositis, all right? And then another differential to worry about is oral candidiasis for most cancer patients, okay? Herpes zoster might present with, something around the lips and all that, simplex. In fact, herpes zoster is very rare because it's varicella, okay? So it's herpes simplex that you will get, okay? So if you saw just clusters of things on the lips, we do again ask that in MRCP. It is herpes simplex, okay? But for this, the answer is oral candidiasis because I didn't show you the image, but it's good to have a differential, okay? Because if you saw the image now, you can get it, isn't it?
Yeah.
All right. So you are not wrong to take mucositis, but with the image if shown, this is thrush, especially for a cancer patient, all right? especially for a cancer patient. And then if you had something on the lips like this here, you could see this, you see this stuff here, okay? The black dot and things. And the answer will be herpes simplex. And you treat with topical acyclovir or something, okay? Zovirax and things like that. Okay, 45-year-old man diagnosed multiple myeloma, presents with acute shortness of breath, thalidomide, investigation, clinical history, blah, blah, blah. What is the most likely diagnosis here?
PE.
Somebody says PE. Any other answer? Any other answer?
I think I'll go with PE.
Go with PE. So PE. So all and every cancer patient coming in with shortness of breath have a high index suspicion that this could be PE. Okay. And of course, in your MRCP, you're going to see your differential of chest X-ray, your Welsh score to really make up your mind. Okay. So a normal chest X-ray, is it in keeping with a PE or not?
Is in keeping.
A normal chest X-ray is in keeping with a PE. I love that. What is the singular most important sign that this is a PE clinically? The answer is tachypnea. Tachypnea. So any tachypneic patient is a high index that this could be a PE. So tachypnea is very high. Okay, that's a PE there. We may show you this as well. Okay. Okay. 32-year-old, massive dilation of the bowel. Okay. Bloating, constipation. All right. Severely constipated with almost ileus looking like pill. So which of the drugs did I say could cause this? Vincristine. Vincristine. Vincristine is an what? Antimitotic. Okay. So the answer is vincristine. Vincristine, massive dilatation, can bung up the bowel. And the therapeutic window is so short and small. Okay, well, I will stop here. The rest is for immunotherapy, where somebody had colitis. If people want to finish it, we can. But I think, so a 70-year-old woman had 4 forks and cycle 2, had severe diarrhea and all that, 6 motions a day. Okay, no fever, no what else. This was the colonoscopy, all right. Was capsaicin induced, so colitis, okay? Colitis is common with 5-FU, capsaicin, CT scan and all that, okay? Taxanes too can cause colitis, okay? And then immunotherapy as well can cause colitis. But as I said, immunotherapy can cause problems in any part of the body, okay? So immunotherapy-related toxicity.
Just give you to update on my handover.
Recognition, timing, investigation is so crucial. Okay, all right. So somebody has diarrhea, nivolumab, ipilimumab, abdominal pain, vomiting, stool is liquid but not watery, no mucus, no blood, diarrhea, liquid stools. Okay, it was on immunotherapy. Okay, based on the available data, diarrhea most commonly occur in patients using combination therapy when? When do you think the diarrhea happens? Anybody? Somebody says a week after first dose, several weeks following treatment initiation. Okay, so diarrhea from immunotherapy, I said it here, I said 6 weeks to 3 months. Okay, usually builds up around several weeks, so 6 weeks or so. Okay, it may build up. Diarrhea from immunotherapy. So this is what I said. So this graph will tell you when diarrhea comes on, okay? You see diarrhea will have shown up between 2 to 6 weeks, all right? Rash and pruritus as well. NFT is probably after 6 weeks. Hypophysitis, you see from 6 months or 6 weeks to 12, okay? Same thing with the anti-PD-1s as well, okay? So going back to that patient had grade 2 related immune diarrhea. What are you going to do?
So just to let you know, so you're talking about them, you can...
I'll finish in the next 5 minutes.
Yeah, sure. Feel free to finish it. And if you can just disconnect all the wires, take your laptop.
Make sure you give them the
The feedbacks,
and
yes,
the certificates as well. Okay.
absolutely. I'll tell Anya.
That's fine. Okay. So what are you going to do for this chap with grade 2 diarrhea, immunotherapy? Again, this is now appearing in your MRCP exams now. Immunotherapy related diarrhea. What are you going to treat with grade 2? What are you going to do? Anybody? Anybody?
Oral steroids.
Oral steroids, okay. Anybody with a different opinion? Begin prednisolone, advise holding immunotherapy, okay? For grade 2. What did I say? Grade 2 means that you've not really been hospitalized, but it's really causing you a problem. Grade 3 is hospitalization. Grade 4 is life-threatening. So begin prednisolone and stop the treatment, okay? Okay, so now, current guidelines, prednisolone, we use 1 milligram per kg or so. Then we reduce immunotherapy is not recommended. You just hold it, all right? Okay, so no point reducing immunotherapy. No point reducing, just hold it on your notes there, all right? Anti-diarrhea medications may be considered as a supportive care, but you'll have ruled out, obstruction or anything, okay? And CDF. So based on available guidelines, the best option is corticosteroids, okay? Immunotherapy should be held until symptoms resolve, okay? Now, Patrick resumes treatment after we held and started steroids, but it turns out late at night with bad abdominal pain, cramping, and severe, and up to 9 motions. 9 motions, cramping, now in hospital, very unwell. What are you going to do? Physical exam, 38 degrees, heart rate, blood pressure, very low there, respiratory rate, 22, very unwell looking chap, heart is tachycardic, very bad, abdomen subtender without guarding, okay? What is the grade now? Okay, somebody says grade 3. Any other person? Any other person? Could it be grade 2? Could it be grade 4? Are we happy to say it's a grade 3? Let me hear from the online group.
Yes, grade 3.
Yes, it's grade 3 because it came into hospital. We will ask these things as well. We will ask, okay? All right, so it's a grade 3 colitis because it came into hospital. So according to the common toxicity criteria, grade 4 is defined as life-threatening, all right? And grade 3 brings you to hospital, but things are a bit shaking, isn't it? All right? And abdominal pain and all that are severe symptoms of colitis, okay? So common toxicity criteria, you must remember that that's what we use. So grade 1, 2, 3, for those of you trying to understand it, okay? Grade 4 is life-threatening. Grade 3 are just severe signs and things and symptoms, but it's not really life-threatening yet, all right? Very good. Grade 2, you can even manage that at home, okay? Okay, so in addition to blood and stool analysis, what else would you recommend at this time? Remember, we are now talking about immunotherapy now, okay? We've left cytotoxic.
Hospitalized, give out fluids, request CT.
Okay, somebody says hospitalized, give IV fluids. Is that correct? Anybody from the online? Is that correct? Correct, okay? Okay, CT scan is very important, okay? And colonoscopy. You don't need to go doing colonoscopy or anything, okay? CT scan is okay. And you see that mesenteric engorgement, okay? So both modalities should be considered based on current available guidelines. You can always do endoscopy, but be very cautious. Now, admitted to hospital, blood samples taken, CT abdomen shows thickened colitis. What are we going to do now? Anybody? Anybody from online quickly? What are you going to do now? We're almost done. What are we going to do? IV steroids, because he's unwell, okay? And he's in hospital. It's not looking good. IV steroids. Okay? You continued on that. And if it's not working, you go to infliximab as a steroid sparing agent. And actually, you introduce infliximab as early as 72 hours if no response. Okay? 3 days, 48 at times by acute oncology guidelines. Okay? They're steroid refractory. Okay? I won't trouble you here now. Okay? So these are all immune toxicity and all that. Okay? Very good. All right. So let me hear from the crowd there. Was that very helpful for immunotherapy? The online group. Any feedback? Does it make you confident around immunotherapy patients now? It does. Okay, very good. Okay, thank you. So give your feedbacks and thanks for listening, okay? All right. Okay, bye-bye. Was that helpful?
Yes, that was very helpful. Thank
So-
you very much.
Because I know you people like it with the case histories. and
Yeah,
things
it
like
gets it registers a bit more. It consolidates a bit more with like the
Exactly.
interactive.
Yeah, because at the end of the day, no matter what I've said,
Yeah.
you're going to see practical, and you're going
Yeah.
to part 2 now.
So yeah,
You're going to part 2. We're
Yeah.
going to ask you these things.
yeah.
So you saw grade 2 was clear.